Firstly, thank you very much for your invitation in this interesting live conference. I am sorry for the problem of connection. So I introduce myself. I am Dr. Habchi Nawel, Algerian neurosurgeon and biologist. I am doing a study on the pituitary adenoma. I am doing specifically the study on the clinical characteristic and the marker of atypical pituitary adenoma. This is why the title of my conference is the Atypical Pituitary Adenoma, Clinical Characteristic and Role of ki-67 and p53 in the prognostic and therapeutic evaluation. So here in my conference, I have two parts. The first part is a general knowledge about pituitary gland, pituitary adenoma, and then we pass to the second part of my conference. It is my study. Next slide. The next, please. So for the what is the pituitary gland? The pituitary gland is a PCZ gland, which is located inside the skull, just below the brain and above the nasal passages. It's responsible for helping to regulate the function of other endocrine glands, such as the thyroid gland, adrenal glands, ovaries, and testes. And we have two parts in this pituitary gland. We have the anterior pituitary gland and posterior pituitary gland. Each gland or each part have a distinct function. Next slide, please. The pituitary gland has different types of pituitary cells. Each cells produce special hormones released into the bloodstream that affect other organs in the body. And from these pituitary cells, we have the growth of pituitary adenoma. So the origin of the pituitary adenoma is the division of this pituitary cells. Next. We have three kinds or types of pituitary adenoma. This pituitary adenoma are a benign tumor and are classified in several different ways according to three criteria and depending upon their property. We have the size, hormone secretion, and aggressiveness. According to the three criteria, we have the microadenoma, the macroadenoma. We have a functional pituitary adenoma and non-functional pituitary adenoma. Next slide, please. According to size, as I say, we have microadenoma. So what is a microadenoma? Microadenoma is a tumor when the size is less than 1 centimeter. However, the microadenoma is 1 centimeter or greater than 1 centimeter in size. So the difference between microadenoma and macroadenoma is the size. Microadenoma less than 1 centimeter. However, macroadenoma more than 1 centimeter or greater more. Next slide. According to hormone secretion, we have two kinds of pituitary adenoma. We have functioning and non-functioning adenoma. The functioning adenoma are the pituitary adenoma that release an active hormone, usually in excessive amount. However, when the pituitary adenoma don't release an active hormones, they are called clinically non-functioning adenoma. For the functioning adenoma, we have example according to the kinds of secretion. We have, for example, prolactinoma, a tumor that overproduces prolactin, acromegaly, and gigantism caused by an excess growth hormone. And also we have caution disease, which is caused by pituitary tumor, which stimulate the overproduction of cortisol. This is the example of functioning pituitary adenoma. The next one. According to aggressiveness, nearly all pituitary adenoma are benign tumor and slow-growing one. An atypical pituitary adenoma, the rarer type, grows more quickly and more likely to recur. So, according to aggressiveness, we have typical adenoma, atypical adenoma, and we have the pituitary carcinoma. Pituitary carcinoma is a malignant tumor that spread to other parts of the body, and it is extremely rare. We have, according to aggressiveness, typical, atypical, and carcinoma. And for the pituitary carcinoma, it is extremely rare. Next slide. We have the fourth World Health Organization, which categorize the pituitary tumor as typical, atypical adenoma, and pituitary carcinoma, as I say. Although this classification does not cover the entire spectrum of histopathological finding or clinical behavior, pituitary adenoma are generally considered as benign because the carcinoma is rare cases, but in some cases, some display high rates of recurrence and or resistant to conventional therapy. So they are defined clinically as aggressive one. Next slide. The aggressive pituitary adenoma seem to represent a distinct entity requiring strict follow-up and early multimodal treatment, nonetheless specific morphological, radiological, and molecular diagnostic criteria that should be identified. This is aggressive pituitary adenoma is considered as a distinct entity, but unlike pituitary carcinoma, this category of aggressive pituitary adenoma do not give rise to metastasis, but the two classes, carcinoma and atypical and aggressive adenoma, the two classes can share some histological feature, and this is why we have doing this study. Second, according to 2004 World Health Organization classification, the atypical pituitary adenoma are defined by an invasive growth, ki-67 or MIB1 proliferative index greater than 3%, a high p53 immunoreactivity, and also an increased mitotic activity. So, according to the fourth edition of the World Health Organization classification of pituitary tumors, this fourth edition recommended the evaluation of a tumor proliferation and also the invasion. So the proliferation and invasion, the two said, and the objective is to identify the aggressiveness of pituitary tumor. Next slide, please. So my study highlights the need to develop a new biomarker in order to facilitate the early detection of clinical aggressive pituitary adenoma, and also to discuss the emerging marker that hold promise for their identification. This is the first objective of my study. Next slide, please. My objective also is to assess the clinical aggressiveness of pituitary neoplasm that were previously defined as atypical pituitary adenoma, and we aim also to assess the prognostic role of ki-67 proliferation index, mitotic index, p53 expression, and the cavernous sinus invasion in the case of pituitary adenoma. Next slide. In the current study, we aimed to report the radiological features, the histopathological finding, and the clinical outcomes of pituitary adenoma, and also to compare the results of typical and atypical pituitary adenoma that were diagnostic using the 2004 WHO classification system. And moreover, based on the idea presented in 2016 WHO classification of a tumor endocrine organs, this study also sought to determine whether it is necessary to remove the diagnostic of the atypical pituitary adenoma category from that classification system or not. So we remove or not the category of atypical pituitary adenoma from the classification of 2017 classification. Next slide. In this sense, a total of 70 pituitary adenoma were included in this study, and 25 of them were diagnosed as atypical pituitary adenoma. The demographic characteristic, the radiological evaluations, clinical information, all this were analyzed, and all the patients underwent endoscopic endonasal transnasal surgery between the period of January 2016 and December 2021. Next slide. The surgical excision specimens were evaluated by a single pathologist, and the cases were categorized as atypical or typical adenoma, and the criteria we have doing this classification according to the 2004 WHO classification. The criteria are excessive p53 immunoreactivity, elevated ki-67 labeling index more than 3%, increased mitotic activity, and finally, atypical morphological feature of pituitary adenoma. This is the fourth criteria that we used in order to categorize the typical adenoma from atypical adenoma. The next slide. For the radiological study and evaluation of invasion, next one. For radiological study, all the patients underwent an MRI scan and also a computerized tomography scan of the paranasal sinuses in order to evaluate the relationship between the adenoma and its surrounding structure. And this is during the perioperative assessment for endoscopic pituitary surgery. This is before the surgery. Afterward, the cases were classified according to classification, Hardy classification and KNOSP classification. Hardy classification was used in order to determine the cellular expansion of the tumor size. However, KNOSP classification was used in order to evaluate cavernous sinus invasion. Next one. Next slide, please. As I say, Hardy classification was used to determine the cellular expansion of the tumor size. According to this classification, we have two types of pituitary adenoma. We have microadenoma and microadenoma and microadenoma. And I say in the part one, microadenoma is adenoma that have a size less than 1 centimeter. However, macroadenoma is a tumor who has a size more than 1 centimeter or greater than. Next stage. KNOSP classification was used in order to evaluate cavernous sinus invasion. We have 11 cavernous sinus invasion in this study. This cavernous sinus invasion was determined by tumor extension by using one line, and this tumor extension is beyond the line corresponding to lateral tangent of the two components of the intercavernous internal carotid artery, and the from ABC. If you see the scheme in ABC, you see the line corresponding to the lateral tangent of the two components of the intracavernous internal carotid artery, and this line is defined by KNOSP and OR. And according to this line, we can define the cavernous sinus invasion. In our study, we have 11 cases. Next slide. The postoperative MRI was performed within 44 hours of surgery, and it was repeated at 6 months, twice a year for the first 3 years, and annually therefore. And all radiological evaluations were performed by the single neuroradiology department, the same neuroradiology department. This is in order to compare the different scheme, the different MRI before the surgery and after the surgery, in order to evaluate the recurrence of tumor or not, if we have recurrence or not. Next. Next. Next slide, please. For the clinical evaluation, full endocrinological evaluation were performed in all the patients. This is before surgery, on the first day, at the end of the first week, at the end of the first month, 3 and 6 months later, and also 1 year after the surgery, and then every 6 months following the first year. Additionally, formal visual field and visual acuity evaluation during the pre and the post-operative period were performed by a single neuro-ophthalmologist. Why we choose the single neuro-ophthalmologist? In order to compare the result of a formal visual field before and after the surgery. Next slide. Next slide. For the histopathological evaluation, all the biopsy samples were fixed in formalin and embedded into paraffin blocks. 4 micrometer thick section were cut for hematoxylin and using staining, and formalin fixed paraffin embedded tissue were used for immunohistochemical study, and the stained slates were evaluated by the single pathologist. The ki-67 proliferation index was evaluated by counting the cell that showed a nuclear positivity among a total of 1,000 cells. This count was repeated for 3 separate times, and then the mean values of this 3 ki-67 counts were calculated. So we obtained the index of proliferation of ki-67 by choosing by the mean values of 3 ki count, the means of 3 values. We do the first one, the second one, the third one, and then we calculate the means values, and we have the ki-67 proliferation index. This is the technique of evaluation of ki-67 proliferation index. Next one. For the result, next slide. Out of 67 pure endoscopic endonasal transphrenoidal surgery treated case, between this 70 pure endoscopic endonasal transphrenoidal surgery treated case, we have found 45 atypical adenoma, and 25 were diagnosed as atypical adenoma. So we have a predominance of typical adenoma in our study, but we are based on the demographic and clinical feature of atypical adenoma. Why this? Because the atypical pituitary adenoma present problems. Here in this table, we have the demographic and clinical feature of all the patient. For example, the median age of patient who present typical pituitary adenoma is 42. However, in the case of the series of patients who present atypical pituitary adenoma, the median age is 32. So the patient who present atypical adenoma is in the age of 30, 34, 35. For the gender, we noticed that in the case of the series of atypical adenoma, we have the predominance of a male. So the category of a man are the predominance category who present atypical adenoma. Next slide. A total of 80% of the typical adenoma and 77% of atypical adenoma were cured after the surgery, but no statistically significant difference was found between the cure rates for typical and atypical adenoma. So this is the first result. There is no statistical significant difference between the cure rate for the two kinds of pituitary adenoma. Next slide. For the reoperation rates, the reoperation rates were 9 and 10% for typical and atypical pituitary adenoma, respectively. This slight difference was not statistically significant, but the cure and reoperation rates did not show any statistical significant difference between the typical and atypical pituitary adenoma. This is a second result. So there is not statistical significant difference between the cure and reoperation rate between the typical and atypical pituitary adenoma. Next slide. Here, there is other difference. Look here for the extension and invasion. Here we have the problem. For the first two results, there is no significant statistical difference between the cure rates and the reoperation between the two kinds of pituitary adenoma. But here there is the difference. In the case of paracellular extension, we have found that a paracellular extension is associated with significantly lower cure rates. Moreover, for the case of cavernous sinus invasion, we have found that this invasion is associated with the cure rates in two cases. Donc, so, moreover, cavernous sinus invasion, which was detected in 11 cases of atypical pituitary adenoma, it was found also. It was also found to be statistically significant factor for a poor cure rate in the case of atypical pituitary adenoma. This is the difference between the first result and the second result. Next one. The cavernous sinus invasion or paracellular extension was found to be associated with a lower cure rate in a patient with atypical pituitary adenoma. This is the result, the best result that we have in our study. Next slide. Also, for the ki-67, we have found a result. When ki-67 labeling index were compared between the cured and not cured atypical pituitary adenoma cases, the difference was not statistically significant. However, a higher ki-67 labeling index was found to be associated with a higher rate of reoperation in the case of atypical pituitary adenoma. Next slide. We pass to the discussion. Ever since the atypical pituitary adenoma diagnostic category was first introduced, and it has been a controversial issue for both neurosurgeon and neuropathologist. Next one. Here we discuss our result. The criteria of atypical pituitary adenoma was based on the result of two major studies conducted by Tupper. And these two studies stressed on the utility of ki-67 labeling index threshold of 3% and also the immunoreactivity or expression of p53. Afterwards, the term of atypical pituitary adenoma was included in the 2004 World Health Organization classification of tumors of endocrine organs. Next one. In the current study, which considered of 70 cases, 25 atypical pituitary adenoma and 45 atypical adenoma, we have compared the invasiveness as assessed by radiological study, reparation and cure rates of atypical and typical pituitary adenoma, and all this is certified according to the 2004 WHO classification system. Next one. So we have found that atypical pituitary adenoma tend to be more invasive than typical one, but without any statistical significance based on the reparation and the cure. This is the best result of our study. So atypical pituitary adenoma is more invasive than typical one, but without any statistical significance based on reparation and the cure. Next slide. Although the reparation rates were not affected by ki-67 labeling index, one acute of values is set as 10%, a statistically significant difference was detected in the case of atypical pituitary adenoma, and this is based on reparation rates. This is on the case on the recurrent pituitary adenoma. Based on the author clinical and histopathological expression, the ki-67 labeling index more than 10% could be associated with aggressive behavior of atypical adenoma. So for me and our medicine, our doctor, we found that when we have ki-67 labeling index more than 10%, we pay attention in the follow-up of our patient. Next slide. The high ki-67, the invasion, rapid growth, these three criteria are considered to represent the clinical aggressiveness, and such adenoma with this feature are defined a high-risk pituitary adenoma in the recent World Health Organization classification of 2017. In the present study, we compared the invasion status of a cured and uncured atypical pituitary adenoma, and we have found that only cavernous sinus invasion who have a negative effect on the treatment result. None of the other factors showed any statistically significant correlation in terms of a cure rate or recurrence for the case of atypical pituitary adenoma. Next one. I have 5 points. My highlights is the first one, the most important parameter to affect the cure in atypical pituitary adenoma is the cavernous sinus invasion. The second point, in the case of ki-67 immunolabeling, if we have ki-67 index more than 10%, here we can say that this tumor can be aggressive, can present aggressive behavior, and we are in the case of atypical pituitary adenoma. The third point, the definition of atypical pituitary adenoma, the atypical pathology, does not contribute to the patient follow-up and the cure criteria. The evaluation of the proliferation by means of mitotic count and ki-67 labeling index, as well radiological feature and intraoperative assessment, all this with the invasion should be taken into consideration when we determine the treatment and follow-up of our patient who present a pituitary adenoma. So we have the evaluation of mitotic account, mitotic activity, ki-67 proliferation index, radiological feature, intraoperative assessment, and tumor invasion. All these four criteria as very important before when we determine a treatment and before a follow-up of our patient. It should be also considered that a strong immunopositivity of p53 and higher ki-67 labeling index, this two immunopositivity could predict an increased risk of a tumor recurrence. But more study and a larger study are expected to confirm and enlarge the diagnostic and therapeutic management process of this lesion. This is we must have a large study in order to confirm this result, because in our study we have only 70 patients who present pituitary adenoma, and we have only 25 atypical pituitary adenoma. We found this result in material. The material of our study is not big. This is why I recommend to have a large study, a large series in order to confirm our results. Next slide. As conclusion, this experience shall use that future research on pituitary adenoma classification should combine the clinical stages of the patient, the radiological parameter, including anatomical relationship, with critical neurovascular structure and the immunohistochemical evaluation. And finally, thank you very much for your attention.